Welcome back to another deep dive. Today we're tackling a really important topic, pancreatic cancer. It's definitely a serious one, but the good news is there's growing awareness and crucially real progress happening in treatment and research.
Absolutely. And we're basing this discussion on a very thorough article you shared covering symptoms, prevention, the whole lot. Our aim today is really to pull out the key information for everyone listening.
Right. The mission, if you like, is to get a clear understanding what it is, the early signs to maybe watch for, the risks, how it's actually detected, and importantly, what treatments look like now and what's on the horizon,
Yeah.
without getting totally bogged down in jargon.
Exactly. We want it to be informative but accessible.
Okay, so let's kick things off with the basics. The pancreas itself. I mean, I know where it is roughly, but the article highlighted its specific jobs. It has two main functions, doesn't it?
It does, yeah. It's tucked away behind the stomach, a bit hidden, and it's got this dual role. First, the exocrine function that's making the enzymes we need to digest food. Really vital stuff.
Okay, enzymes for digestion. Got it.
And then there's the endocrine side. This is where it produces hormones, crucially insulin and glucagon, that manage our blood sugar levels.
Huh.
So yeah, it's working hard on two fronts.
Makes sense. And the cancer itself, it's not just one single type, is it? The article mentioned two main categories.
That's a key distinction. The vast majority, we're talking maybe 90 to 95% of cases, fall under the umbrella of pancreatic adenocarcinoma. These start in the ducts, part of that exocrine system we just mentioned.
And those are the ones that are often described as quite aggressive.
Exactly. They tend to be aggressive and unfortunately often quite resistant to treatment. That's a major challenge. The other type, much less common, maybe around 5%, are pancreatic neuroendocrine tumors, or PNETs.
That's right.
Yeah, these come from the hormone-producing cells, the endocrine part. Generally speaking, they tend to grow more slowly than adenocarcinomas. But, given how common adenocarcinoma is, that's where a lot of the focus lies.
So that prevalence and aggressiveness really highlights why pancreatic cancer is considered so dangerous. It's about how it behaves.
Precisely. The article really stresses two things. One, its tendency to spread, metastasize quite quickly to other organs. And two, that resistance to treatment we talked about, especially with adenocarcinoma, it makes it a really tough opponent.
Which leads us straight into why spotting it early, if possible, is so critical. Let's talk symptoms. The breakdown into early and late stage was helpful, I thought.
It is helpful, yeah. But the difficulty, the real problem is that early on, the symptoms are often, well, they're just not very specific. They can be mild, easily ignored, or sometimes there aren't any symptoms at all.
Like, what sort of things are we talking about early on?
Things like unexplained weight loss, losing weight without trying, or maybe just losing your appetite, not feeling hungry. Sometimes a vague discomfort in the tummy area, easily mistaken for indigestion or something minor.
And you flagged something interesting earlier from the article about new-onset diabetes.
Yes, that's a really important potential clue. If someone suddenly develops diabetes, especially if they don't have the typical risk factors like being overweight or having a family history of it, that new onset aspect could potentially signal something underlying like pancreatic cancer. Definitely needs checking out.
So subtle signs early on, but then as it progresses, the symptoms become harder to ignore.
Definitely. The advanced stage symptoms are usually more pronounced and really should trigger a doctor's visit immediately. Jaundice is a big one, that yellowing of the skin and the whites of the eyes. It happens when the tumor blocks the bile duct.
Okay, jaundice. What else?
Severe pain, often in the abdomen or even radiating to the back. The article notes it can be worse at night or after eating. That characteristic can be a clue.
And there were some other physical signs mentioned too.
Yes. Changes related to digestion. Things like pale, greasy, floating stools that points to problems digesting fat because the pancreatic enzymes aren't getting where they need to go. Dark urine can also happen, linked to that bilirubin buildup from the bile duct issue.
Right.
And nausea, maybe vomiting, especially if the tumor starts pressing on or blocking the stomach. Oh, and one more thing the article mentioned, unexplained blood clots, like a DVT, a deep vein thrombosis appearing out of the blue.
That's quite specific. So the article had a very clear warning here, didn't it?
It did, basically. If you have persistent jaundice, sudden significant weight loss, or that severe abdominal pain, see a doctor right away. It's not about panic, it's about being informed and taking action, empowering yourself with that knowledge.
Absolutely. Knowing when to act is key. Okay, let's shift gears a bit. Who is more likely to be at risk? The article split these into factors we can't change and factors we might be able to influence.
Yeah, that's a useful way to look at it. So the non-modifiable ones, the things we can't control, Age is definitely one. Most diagnoses happen in people over 65.
Okay, age.
Family history is another. About 10% of cases seem to have some hereditary link. Sometimes this involves known genetic syndromes,
Hmm.
like those associated with BRCA gene mutations, the ones often linked to breast and ovarian cancer or Lynch syndrome.
So if you have those gene mutations in your family, it increases the risk.
It can, yes. It's like having a faulty instruction in your cell's blueprint that makes certain cancers, including pancreatic, more likely. It highlights why knowing your family medical history is so important.
What else falls into that can't change category?
Chronic pancreatitis, that's long-term inflammation of the pancreas itself that increases risk. And having diabetes, especially type 2 diabetes that you've had for a long time.
Right. But then there are the modifiable factors, things we potentially can do something about. This is where prevention tips come in.
Exactly. And top of the list is smoking. Quitting smoking is probably the single most effective thing someone can do to lower their risk. Smokers have a much higher risk, like 2 to 3 times higher.
Huge difference. What else?
Maintaining a healthy weight is important too. Obesity is linked to about a 20% increased risk. Limiting alcohol is also advised, mainly because heavy drinking can lead to chronic pancreatitis, which, as we just said, is a risk factor.
So it's kind of an indirect link there with alcohol.
It often is, yeah.
Yeah.
Then there's diet. The advice is pretty standard, healthy eating guidance. Really more fruits, vegetables, whole grains, and less processed meat. Regular exercise helps too, likely by reducing inflammation and helping with insulin sensitivity.
And for people with diabetes?
Good blood sugar control seems to be important. Managing diabetes well might help lower the associated risk.
It's interesting how many of these overlap with general health advice. Good for the pancreas, good for everything else too. Okay, so diagnosis. We've said it's tricky because symptoms appear late. How do doctors actually go about diagnosing it?
Well, imaging tests are usually the first step if pancreatic cancer is suspected. A CT scan is often the workhorse here, used to get a good look in the pancreas and see if there's a tumor.
CT scan first, typically.
Yeah. Then an MRI or something called an endoscopic ultrasound, or EUS, might be used. These can give even more detailed pictures. A PET scan is sometimes used to see if the cancer has spread elsewhere in the body, checking for metastasis.
But pictures alone aren't enough for a final diagnosis, are they?
No, you need confirmation. That requires a biopsy taking a small sample of the tissue. This can be done with a needle guided by ultrasound or CT, or sometimes during surgery. That sample then goes to the lab to be checked for cancer cells.
And blood tests. The article mentioned one, CA1999.
Right. The CA19-9 tumor marker. It's a substance that can be elevated in the blood of people with pancreatic cancer. But, and this is important, it's not a perfect test for diagnosis.
Why not?
Well, levels can be high for other reasons, not just pancreatic cancer, leading to false positives. And some people with pancreatic cancer don't have high levels, so you get false negatives too. It's often more useful for monitoring how someone is responding to treatment rather than for the initial diagnosis itself.
Okay, so helpful, but with limitations. But the research section sounded quite hopeful about new detection methods, like liquid biopsies.
Yes, that's a really exciting area. Liquid biopsies are essentially blood tests, looking for tiny fragments of DNA shed from cancer cells that might be circulating in the bloodstream. The potential here is huge. Well, imagine being able to detect the cancer much, much earlier, maybe even before symptoms start, just from a blood test. That could genuinely be a game changer for improving outcomes. Earlier detection usually means more treatment options.
That really would be incredible. All right, let's talk treatment then. What are the main approaches? The article stressed that it really depends on the stage of the cancer.
Absolutely crucial point. Surgery offers the best chance for a cure, but, and it's a big but, it's only suitable if the cancer hasn't spread. The article mentioned only about 15 to 20% of people are diagnosed early enough for surgery to be an option.
So a relatively small percentage. What kind of surgery?
It depends where the tumor is. The most common is the Whipple procedure. That's for tumors in the head of the pancreas. If it's in the tail, it's called a distal pancreatectomy. Very occasionally, the whole pancreas might need removing a total pancreatectomy, but that's quite rare.
Okay. And for the majority who aren't candidates for surgery, or maybe after surgery, what else is used?
Chemotherapy is a cornerstone. The article mentioned common combinations like FOLFIRINOX or gemcitabine plus Abraxane. Chemo can be used before surgery. They call that neoadjuvant to try and shrink the tumor. Or after surgery, adjuvant to kill any remaining cells. And it's the main treatment for advanced cancer that is spread.
Right. And radiation.
Radiation therapy is sometimes used too, often alongside chemotherapy, particularly to target tumors that can't be removed surgically or to help manage symptoms like pain.
The article also touched on newer types of therapies, targeted therapy and immunotherapy.
Yes, this is where treatment is becoming more personalized. Targeted therapies go after specific genetic changes in the cancer cells. For instance, PRP inhibitors, like a drug called olaparib, can be effective for cancers that have those BRCA mutations we mentioned earlier.
So matching the drug to the specific mutation.
Exactly. And immunotherapy, which boosts the body's own immune system to fight the cancer, is showing promise too, but currently mainly for a smaller subset of pancreatic cancers that have particular genetic features. A drug called Keytruda was mentioned as an example.
It sounds like knowing the genetic makeup of the tumor is becoming increasingly important.
Definitely. It helps guide these more tailored treatment choices. And finally, we shouldn't forget palliative care. The article rightly emphasized this.
Yes, explain that a bit more.
Palliative care is all about managing symptoms and improving quality of life at any stage of the illness. It's not just end-of-life care. It includes managing pain, dealing with jaundice, maybe putting in stents to open block ducts, controlling nausea, providing emotional support. It's a really vital part of comprehensive cancer care.
That's a great point. It's about the whole person, not just the disease. Okay, looking forward now. The end of the article struck a hopeful note, focusing on the research horizon.
Yes, and there's some genuinely exciting stuff happening. We've already touched on the push for better early detection AI, helping read scans, those liquid biopsies we discussed. Getting that diagnosis earlier is a huge goal.
And beyond detection, I saw mention of personalized vaccines.
Yeah, this is fascinating. The idea is to create a vaccine tailored to an individual patient's tumor, essentially training their immune system to recognize and attack their specific cancer cells. Very personalized medicine.
Wow. What else is showing promise?
Well, KRAS inhibitors are a big deal. KRAS is a gene that's mutated in the vast majority of pancreatic cancers, but for decades it was considered undruggable. Now, there are finally drugs being developed that can target KRAS mutations. That could be a major breakthrough if they prove effective.
Targeting the most common driver sounds crucial.
Absolutely. And also, nanotechnology, using tiny particles to deliver drugs directly to the tumor, potentially making treatments more effective and reducing side effects. Lots of different angles being explored.
And underlying all this progress is clinical trials, right?
Couldn't agree more. Clinical trials are essential for testing all these new ideas, the new drugs, the vaccines, the detection methods. It's how we find out what works and move the field forward. The article even points people towards clinicaltrials.gov, which is a great resource to find ongoing studies. Participating is not just potentially beneficial for the patient, but it helps everyone in the long run.
So wrapping things up, it's clear pancreatic cancer is a formidable challenge, no doubt about it. But the takeaway seems to be that knowledge really is power here, and real, tangible progress is being made.
That's exactly it. It's not about false hope, but recognizing that increased awareness, better understanding of risks, and these ongoing research advancements are making a difference. It really drives home the importance of being proactive with your health, talking to your doctor, especially if you have risk factors.
And for listeners who might be navigating this personally or supporting someone who is, resources like support groups PanCan was mentioned can be invaluable. You're not alone.
Definitely not. Connection and support are so important. And that final thought from the source material really resonates. Knowledge is the greatest weapon. Stay informed, proactive, and hopeful.
It certainly makes you think, doesn't it? How this relentless push in pancreatic cancer research shows that dedication and curiosity really can tackle even the toughest medical challenges. It leaves me wondering what other health frontiers, maybe ones that seem just as daunting today, might be on the cusp of similar breakthroughs because of the research happening right now. Something to ponder until our next deep dive.